welcome to Six Patterns. We have a beautiful case for you today. One of the classic pulmonary pathology cases.
Great.
My name's Max.
I'm Kevin, and we're going to look at some nodules. Now, you know, we always say that nodules are dominated by tumors. But if you take a second to look at this poster, it will remind you quickly of how many things can produce nodules. In fact, if you look at the list underneath pattern 5 nodules, we have granulomas with and without necrosis. We have lymphoid cells making nodules. We have necrosis alone. We have atypical cells. We have stellate scars. These are all the things you should be thinking about when you look at nodules. So you can look at a nodular case off the cuff and just wing it, and hopefully you'll remember the things that make nodules. But my advice and Max's advice is that you use some sort of a map to guide you. So these nodules, Max, to me look like they have a couple of colors, pink and blue.
Multiple colors, pink and blue. And it's not just one nodule.
Right.
This isn't a single spiculated mass.
Right, exactly. There are almost too many nodules, really, for this to be a case of tumor, per se, only because if it's metastatic disease, it's not going to get biopsied with a surgical wedge. Right? The patient's going to have known colon cancer, going to have multiple nodules. So to get this kind of a biopsy, it's telling us there's something funny clinically about this patient's nodular disease. And when we get closer to these nodules, they're fairly rounded, but it looks like to me there's writing inside of this nodule.
Yeah, these irregular blue areas.
Right.
They kind of have a geographic appearance.
Geographic, serpiginous, a great pathology term, meaning snake-like. And these areas are blue in their center, and they look to me like necrosis as we get closer. So blue necrosis making irregular shapes within a nodule, sometimes even looking like unusually placed letters from the alphabet. So I think necrosis is present here, and I see a lot of epithelioid cells around the edge of necrosis. So I guess this is necrosis in a granulomatous disease.
I completely agree. Necrotizing granulomatous inflammation, you get a sense of some palisading of the histiocytes around this necrosis.
Meaning they're lining up, or what do you mean by palisading?
Meaning they're lining up next to each other, and they're forming this sort of organized ring around the areas of necrosis.
Right, like little soldiers watching the fire burn.
And very rare multinucleated giant cells. There's a few.
Right.
But they're very rare. Now, when we have visitors in pulmonary pathology, I say necrosis in a wedge biopsy, outside of tumor, if you have necrosis, the differential diagnosis is infection, infection, infection. Right. Necrotizing granulomas are infection almost all the time.
Until proven otherwise.
Unless they're not. There's just a few caveats to that mantra that right. Necrosis is always associated with infection.
Right.
And one of those caveats is, of course, this disease.
Right. Now, if this is necrotizing granulomatous infection with this many nodules in a surgical biopsy, what would you think this patient's clinical condition would be?
An outstanding question, because oftentimes this question is the most important question, regardless of any of the pathology. But if you have a patient with this type of necrotizing nodular disease, and it's due to infection, they're going to be sick as a dog in the ICU,
right.
on a ventilator, almost ready to die.
Right.
They'll be septic.
Right. A little bit of necrosis goes a long way with infection, and this is way too much necrosis. So if you tell me that this patient was sitting in the office, a little short of breath and having some fatigue and a little cough and maybe a little bit of nasal discharge, I think we start getting closer to the correct answer here. This is way too much pathology for a patient who isn't really sick.
Exactly. So you're thinking it's...
I'm thinking this has to be GPA.
Granulomatosis with polyangiitis, formerly
right.
known as...
Wegener granulomatosis.
Wegener granulomatosis. Now, I have to ask you a question, though, because this is a vasculitic disease.
Right.
Wegener's granulomatosis, microscopic polyangiitis. Those are vasculitic diseases.
Right.
And here I see a pulmonary artery. It's right next door to an airway. And I don't see any vasculitis. So how can we say this is Wegener?
It's a pretty big artery too.
It's a big artery.
So when the big arteries are unaffected, it doesn't exclude the possibility that we've got microvascular arteritis. So I think when you look at the natural history of GPA, the necrosis begins as a necrosis of collagen. So it doesn't begin as a granuloma that necroses in the center. It begins as a focus of necrosis that gathers the histiocytic reaction at its perimeter.
Here
like
is
this.
the very earliest lesion of GPA. Collagen necrosis. We have karyorectic debris, pycnotic nuclei, with this early palisade of histiocytes around the outside.
Right.
Now, if you had a needle core biopsy of a mass lesion and this is all you had in the correct clinical setting, I think that's probably enough to suggest the possibility of GPA.
Yeah, and it should be on the mind of your clinical colleagues, because GPA does produce in its nodular form pretty spectacular findings on CT and chest x-ray. And it usually raises the possibility with the clinician of a vasculitic disease because the patient has other problems. For example, disease typically within the hand's breadth of the tip of the nose. So up in the sinuses.
Sinus disease.
Even in the ears, the middle ears, you may end up have vasculitic reaction in the small vessels of the auditory system, and you can have hearing loss as a presentation in GPA.
And of course, renal disease is one of the most important questions to ask. Does the patient have any evidence of renal insufficiency, active urinary sediment, etc.? Because patients with pulmonary disease like this and renal disease, you're talking about a systemic vasculitis, and GPA would be at the top of the differential diagnosis.
Right.
So it's not uncommon in cases of GPA to have these areas of fibrin and organizing pneumonia adjacent to these larger nodules. In fact, the spectrum of pathology that you can see in GPA is actually quite broad. And we classically talk about the geographic basophilic necrosis with palisading histiocytes, but there's a wide array of acute lung injury and even some fibrotic patterns that you can get as GPA progresses and undergoes scarring, like we have here, some more advanced scarring.
You know, when I get to a place where I'm thinking this patient likely has GPA, I put a test on the case and I say, if this is GPA, I should not be able to find one granuloma in this biopsy that doesn't have necrosis at its center.
That is a great point, because infection usually has some granulomas that are non-necrotizing.
Right. So if you could search around and find what is obviously a granuloma that has no necrosis, I would think more of infection than I would of GPA. So I use that as a way to test my impression of GPA.
The other helpful thing for GPA is these types of giant cells. They're these, I call them angry. They're angulated, they're smudgy. It's hard to make out where their nuclei start and stop. It's not those big, plump epithelioid giant cells that you see in something like sarcoid or even infection-associated necrotizing granulomas.
So how are we going to confirm this? We have the impression, we think that's what this is. Do we just sign it out? How would you sign this case out?
I would sign this out as geographic necrotizing basophilic granulomas consistent with granulomatosis with polyangiitis.
Confirm with?
Onca testing.
Onca testing. So we do need to involve the clinician in serology here. Maybe the Onca tests have not been performed. You've got to get on board quickly with this, because some patients with Wegener granulomatosis, GPA, can bleed. Now, the nodular forms with necrosis don't tend to be the hemorrhagic form of the disease, but they can bleed even though they may be nodular and necrotizing, and the bleeding can be fatal. So you do need to move.
Phone call.
It deserves a phone call, and you got to be ready to suggest the possibilities. Does the patient have nodules on CT scan? Obviously, they will have. Have the studies been done, the serologic studies? Does the patient have disease in the vicinity of the sinuses?
Is there renal disease?
Is there renal
What's
disease?
the creatinine? What's the urinary
sediment? Right. You got to be able to navigate this with the clinician to help them make the correct diagnosis.
Okay, so beautiful case of granulomatosis with polyangiitis. Don't forget to like and comment below.